The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, back again this week with Dr. Kirti Sivakoti, talking about POTS. And, I'm glad that we're having her back on. As I mentioned a couple of weeks ago when we started all this, some of this is just me needing to sort things out. And I think that this is a difficult enough problem that if I'm struggling this much with it, that look, we can all work on this together. Welcome back, Kirti.
Yes, thanks for having me back.
Have you developed any disclosures you'd like to talk about?
I have not.
All right. Any particular things you want to talk about, that just you want to get off your chest? What's bugging you?
What's bugging me? I would say this has been great. This has been great, sort of like integrating everything, and great opportunity to share this with my colleagues and community.
All right. So we want to talk this week about both how POTS plays out and the future of POTS. And so in some ways, this is the future of POTS in the individual patient and the future of POTS in the world. What do we understand about the prognosis of POTS? What percentage of patients get better?
Yeah, so that's a great question. And there are not a lot of studies around this, but there's one paper that has come out, and this is out of CHOP, where they looked at long-term outcomes of patients with POTS. And what they did is teenagers who had a diagnosis of POTS, they followed them a decade later. And what they found is overall, their symptoms had improved, although some continued to use medications, and they went on to college and do all the things that they wanted to do. But I think the outcome, the way they phrased it, is that it continues to be a diagnosis on their chart. Some of them could struggle still if they have predispositions, the hypermobility, whatnot. But overall, with implementing the things and doing the physical therapy and everything, a lot of them improved significantly.
Is there a typical timeline, or is that very variable based on the patient? As you've suggested, there are some things where we can see a connection, and we're going to come back to that a little bit, like a concussion or an illness. Are those patients more likely to improve than the ones where it's more mysterious, or is it the other way around, or is it completely unpredictable?
So the answer to that, I want to say yes, based on some clinical experience, definitely not published data, but response to different subtypes is definitely different. So some of our physical therapists will talk about how when patients have post-infectious POTS, we know for sure that this is post-infectious POTS versus somebody who has post-concussive POTS. The ones with post-concussive POTS tend to recover better with physical therapy. They tend to get back into functioning a lot easier, a lot faster compared to the ones with post-infectious POTS. But with that being said, we don't have concrete ways of subtyping this population and saying for sure that this is the outcome. I think we definitely need data, but some of the theories that they have thrown out there is that the fact that they have some inflammation already going on, and exercise is increasing their inflammation, so they're getting worse. The post-exertional malaise is making them worse. But for post-concussive POTS, is the rehab helping them? So I think there are some differences, but we don't have data to back that. We definitely need really good longitudinal data on how different patients respond to physical therapy over time.
What can you tell me about the connection between long COVID and POTS?
Yeah, so long COVID and POTS, thanks to COVID, the diagnosis of POTS has definitely increased. And I think it's a combination of, true increase in the disease per se and increased recognition. So we had patients who had post-infectious POTS before that, mono or flu, whatnot. But I think with the larger amounts with COVID, it definitely brought that to national attention. We see similar patterns between patients who have POTS and long COVID, except that long COVID POTS seem to have higher degrees of fatigue and higher degrees of like palpitation, tachycardia related symptoms compared to patients with traditional POTS. The other interesting thing that I also find, I think, differences between long COVID POTS and traditional POTS is with long COVID POTS, we know a trigger, like these patients have had a COVID diagnosis and then they went downhill. So it almost expedites their diagnostic journey. So they get diagnosed faster, they get plugged into
Oh.
services faster compared to traditional POTS, where we can't put our finger, the symptoms are still, multisystemic, whatnot. So there's a longer time to diagnosis for these patients. So this is also something we have seen in our clinic, not published data, but we have seen the ones who are coming in get diagnosed with long COVID POTS are way faster, like timeline of 6 months, 9 months. Compared to POTS, it could be years.
And again, is that related to just the profile of this disease, or are you doing things differently, or does the early recognition in the recovery?
Yeah, so early recognition, we think definitely hastens their recovery because they're not getting significantly functionally impaired before we are catching them. They are just starting to miss school. They're just starting to have tummy symptoms. And then we integrate all these rehab methods compared to somebody who has been waiting 5 years to get a diagnosis. Now, for them, I think there are additional things. There's the secondary deconditioning that makes it harder to recover, or now there's significant anxiety or depression secondary to the illness process. That's an additional barrier. So I think it gets harder to manage once they have been sitting with the illness for longer. But again, we need more data for that too.
You touched on this a couple of weeks ago, but I'd like you to expand on it a little bit if you can. What do we know about the connection between POTS and eating disorders?
Yeah. So eating disorders in POTS, I think we have seen it both ways. We have seen patients who have had eating disorders who, whether secondary to their weight loss, there's sort of significant autonomic dysregulation, and now they're coming into our clinic with POTS type of symptoms. And these patients are the ones we really struggle with because we know that there has been this significant trigger, metabolic derangements and things like that. Should we even label them POTS? And I think we come back to the same discussion about POTS. We are just using heart rate to identify this population, but I think it's very heterogeneous and the causes are so different. We definitely know that there are some eating disorders that could cause autonomic dysregulation in patients secondarily, but then the bigger pattern that we see is whether it's just feeding preferences or the way they're eating or POTS related food intolerances or disorders of gut brain interaction that's triggering this, but it leads for patients to be like, I'm not hungry, I don't want to eat. And over time, it becomes a habit. And they also get it to a place where if I eat, I'm going to vomit, or if I eat, I'm going to be nauseous. So I'm just not going to eat. So I think there's also a secondary process that happens. So we try to involve our nutritionists to help understand patients, help them understand their feeding cues and get back to their goals.
Let's talk about some other comorbidities. We touched on this a couple of weeks ago, but I was hoping you could expand on it. And that's connection between some functional disorders and or pain syndromes and POTS. Is there a connection there?
Yeah, so we definitely think that there's a connection between functional syndromes and pain syndromes and POTS. When we're thinking about POTS and if there is autonomic dysfunction, some sort of transient injury to autonomic nerves, one common mechanism that could be also driving pain is there some sort of small fiber neuropathy that now leads to pain in these patients. I think we recognize that more so in adults, but in pediatrics, we don't have data for that. We don't even have data for what is a good small fiber density when we look under a microscope. So we definitely need more data there. But there's some thought about some unifying pathologies, but also when patients have, let's say, autism or neurodivergence, are they processing signals differently? Do they have pain because of how they're processing things? Or is there comorbid amplified musculoskeletal pain diagnosis or a CRPS, a complex regional pain syndrome diagnosis? So we see that they go hand in hand, and why it happens, we don't know exactly. So even in our dysautonomia clinic, we have two arms to our clinic. We have dysautonomia. So we see POTS patients and the orthostatic intolerance patients, and the other arm is chronic pain. And honestly, we feel like it's the same patient population, and it seems to be a little bit more of either pain or orthostatic symptoms in this population.
So not an either or so much as a how much of each.
Exactly, yes. And yes, there could be some patients who have purely a pain syndrome, CRPS, and there are some who purely have POTS, but I think most patients fall somewhere in the middle.
Can you expand a little bit more on the particular challenges of treating POTS in a neurodivergent population?
Yeah, so neurodivergence, it definitely introduces some challenges when it comes to being able to manage POTS symptoms better. So let's say if there's ADHD, when we think about treating POTS, we are asking our patients to remember to drink water, to have their salt and compression and exercise. It feels like a whole lifestyle change if their ADHD is untreated, or if the demands of what we are asking is higher than what they can, that could become a barrier for treatment. Same for autism. Just their unpredictability with their health can cause a lot of issues for patients. They have a hard time tolerating compression garments. And then also they have a harder time sort of cueing into their body signals. And this is actually one population where wearables could be helpful, where we can understand that what is their heart rate doing? Is patient able to recognize that or not? Mood disorders, if they're comorbid mood disorders, anxiety and depression, we want to be able to treat that because we know that they mediate functioning in this population.
How often do POTS patients need treatment for a mood disorder?
That's a great question. I want to say over 50% of our patients who come in are on some form of SSRI. So it's definitely helpful to treat that because now it's easier to treat POTS symptoms. We have had patients where anxiety and depression could be comorbid, and we want to really get a good history in terms of, do you think your anxiety and depression, they're worse now? And sort of the questions around that. Do you think they're worse and your POTS symptoms worse? Are they going on parallel track? Or do you feel anxiety is better, but your POTS symptoms are worse? So I think that gives us really valuable data because there are some patients who will talk about, I had really bad mental health issues, crisis 5 years ago, but that's under control. I've done therapy, but now my POTS symptoms are, it's really worse and I want to work on this. And there are some patients where we walk in the room and they're having panic attacks, and then we talk to them about really need to treat your anxiety because that's going to help your POTS symptoms, but also like if there's so much sympathetic activation, how much of your heart rate elevation is just coming from being anxious when we do this. So I think there's definitely some nuance there. We want to manage anxiety and depression, but at the same time, we want to definitely recognize that POTS is a different entity on its own. This could be mediating functioning.
Where do you see POTS going over the next while? Where's the promise in what you're seeing? Where are the challenges in what you're seeing?
So the promise definitely is that we are leaning towards, research is leaning towards phenotyping, subtyping, and clinically there's more acceptance. We're definitely not in a place where we're having to talk about is POTS real or not. The stigma component is going
Sure.
away. And I think there is a lot of recognition that this is real. And the promise is more providers are interested in learning about this and they want to take ownership of the patients. And I think there's increased recognition that this can be managed under the general pediatric umbrella, but thinking about how do we manage those barriers in terms of time, in terms of having staff trained to do the orthostatic vitals interpretation and messaging of some of these things to families. Because I think families will really be confident in their diagnosis if we are confident in how we are approaching it. If we talk to families about your tests are normal, I don't know, we'll just refer you here, I think they tend to feel a little less confident. Or if we talk about, we'll refer you to physical therapy and to psychology, but we're not framing them appropriately, there's a chance that they don't understand why we are doing it and won't do it.
Very helpful. Let me ask you a couple of lightning round summary questions. What do you think is the most misunderstood thing about POTS?
Yeah, so I would say the most misunderstood thing about POTS is we're looking at POTS as one disease, but it almost is similar to we using heart rate criteria to identify this subgroup, but it's actually heterogeneous. There are multiple different things that are going on, similar to coming back to the fever analogy. There are multiple different things, and POTS is just the final common pathway, is what we are seeing. We're using heart rate for our convenience to measure a pathway that's going on in these patients.
Do you think that there may be a most overused test that someone like me may do that may obscure either the diagnosis or what we ought to be doing?
Most overused test to obscure.
You can,
That's yeah.
you can pass if you want.
I don't know. What I would say is definitely using heart rate is helpful in that it helps us define this, but excessive reliance on that can help us miss a large category of patients too.
Okay. What do you think is the most undervalued intervention for patients with POTS?
I really think it's behavioral health. I think it's a psychology. And so framing that from a sense of, yes, POTS is, we know that there's heart rate changes and we need to work on volume expansion. There are other mechanisms to it, but a large part of management is how do we get them back to functioning, school reintegration, things like that. So I think behavioral health is a very important component of it. It's similar to like diabetes management. We'll probably have diabetes nurse who's also helping them with other things, behavioral health component for most chronic disorders. So I think that is the most undervalued treatment.
Do you find that social media is helpful in decreasing the confusion around POTS?
I think it probably is increasing the confusion around POTS.
Okay, that was the only one that had a gradable answer. No, it makes me worse. I mean, in that light, I think that sometimes what happens with this and many other things is that I think it sometimes makes people want to look beyond the mark, that there's one more test, there's one more supplement, there's one more thing you haven't thought about.
Right.
And it seems to me, correct me if I'm wrong, it seems to me that what happens in the process is that you don't get to engage in what really does help.
Yes, you're right. And I think that is one of the downsides of social media, where I'll have patients who will send us a message like a couple weeks after the visit, and they're like, I happen to see this online that Lyme's disease could cause that. Should we test for Lyme? And now we're down this rabbit hole.
Right.
And then we're talking about the interventions like that we discussed during the visit. So you're right. I think there's sort of a lot of emphasis on things that are not validated. So yeah, we definitely need more social media information that talks about the rehab methods, the exercise, the volume expansion, and all of those.
And look, I'll be the first to say that I've had many patients who have done some of their own research and have happened upon the right answer. The internet is a very powerful tool, and it behooves me to listen. But the thing that I find discouraging is when people can't settle in and say, let's make a difference, even if that means let's do what we can while we can. And I'm perfectly open to keep thinking.
Yes, absolutely. So it's so interesting. Most of the POTS diagnosis, so we just finished a qualitative study where we interviewed patients on how did you come up to POTS diagnosis? What really helped you? And the answer that most patients had was not a specific healthcare, like a pediatrician or somebody telling them, but they have been to maybe 5 or 6 doctors already, and then somebody, a nurse or MA or somebody said, your heart rate went up so much, you could have POTS. Or maybe they looked up something online. They talked about, maybe you have POTS, you should get that checked out. And when they suggested to their clinician is when they end up getting diagnosed.
Yeah. And again, sometimes it's us who are missing the opportunity to make a difference in someone's life. Anyway, this has been very helpful. I feel a lot clearer about all of this stuff. I really appreciate you being with us again. Thank you so much for joining us. I hope you're willing to come back and answer some questions next week, because I'm sure there will be some good ones.
Yes, thanks for having me.
Thanks for sharing your expertise with us. And thanks to our listeners. Please tell your friends and relatives and, I don't know, people you meet on the street about us, because that's the only way we find new listeners. And thanks to Elisa Stoddard for making this sound like a podcast. And thanks, Janice, for listening. We'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who composed the theme music. See you next time.